Hello everyone, a very good morning. Today let's discuss on a very important essay question, that is an approach to a child with fever and rash. So I've taken this topic everything from our Nelson Pediatric Decision Making book and from the Indian Journal of Dermatology article. Okay, yes, starting off with the introduction. So fever with rash are components of many disease process. So most of them are benign self-limited conditions only. Okay, and here we have etiology. The etiology can range from infectious and non-infectious agents and are included in the differential diagnosis. So etiology can vary from infectious and non-infectious agents. So in infectious we have viral, bacterial and rickettsial things. Okay, starting off with the infectious agent is viral. So what are the viral things or viruses that can present to a child with fever and rash? Mainly it is your measles. Second will be your rubella. Third is your varicella, that is your chickenpox. Fourth, Coxsackie. Coxsackie will cause hand, foot, mouth disease to the child. Fifth, dengue. Dengue, you will be seeing petechiae, recovering rash will be present in chikungunya. Seventh, in influenza and your adenovirus. These all can cause a child to present with fever and rash. Coming to a bacterial agent which can present with fever and rash are Staphylococcus, Group A Streptococcus. Third will be your Neisseria meningitis. Fourth will be your Salmonella typhi. In Salmonella typhi, in typhoid fever, you will be getting, that is in your enteric fever, you are getting rose petal like rashes with coated tongue. Next in your Listeria monocytogenes. Okay, these are the bacterial conditions that can lead to child with fever and rash. Coming to the rickettsial, first one is your scrub typhus. Scrub typhus will cause SR in the child. I'll show you the pictures. Next will be your Coxiella bruneti, which will cause your Q fever. Okay, so these are the some of the etiological agents that can produce child with fever and rash. Coming to your non-infectious group, first one will be your collagen disorders. Okay, in collagen disorders, one will be your systemic juvenile rheumatoid arthritis. Systemic juvenile rheumatoid arthritis. Second one will be your SLE. Third, Kawasaki disease. Fourth will be your HSP, Henoch-Scleral purpura. Next will be polyarthritis nodosa. Sixth will be your venous granulomatosis. These are collagen disorders that can lead to a child with fever and rash. Next will be your next topic in your non-infectious agent is your drug hypersensitivity reactions. Your drug hypersensitivity reaction that can cause fever and rash are your Stevens-Johnson syndrome, toxic epidermolysis toxic epidermal necrolysis. Fourth will be your dress is nothing but drug reaction with eosinophilia and systemic symptoms. I'll write it here. Drug reaction with, this is a big topic, okay? Eosinophilia and systemic symptoms. I have tried to cover most of the points in this topic that all you're necessary for you to write in your 10-mark question, because when they ask a 10-mark or a 15-mark question, you need to write at least 10 to 15 pages. You have to nearly cover 10 to 15 pages. So for that you have to write all the points whichever I'm telling. Okay, yes, because I myself made it a made it this as a cut short topic only, so please try to write all the points which I have made it in this video. Yes, going on with the child presenting to you with the, so these are the etiology, that is, one is your infectious, next will be your non-infectious. In infectious it is EC, that is your viral, bacterial and rickettsial infection. Coming to a non-infectious, you have collagen disorders and drug hypersensitivity reactions. Next, coming to a child who are presenting to you with a fever and rash, you first perform a history to the child. You will ask history and do an examination. In history, what are the questions you should ask to the child? First one will be your characteristic of rash. Regarding the characteristic of rash, that is whether the child is having a pruritus, whether there is presence of pruritus, pain, tenderness. Third one will be appearance of the rash in relation to fever. Okay, appearance of rash in relation to fever. Fourth will be how is the progression and evolution of the rash, and whether they had any history of contact with ill persons, or were there any travel history, exposure to pets and animals, insects. Insect bite can also cause fever with rash. Medications, it is IV drug use or something like that. Okay, so these are the history you should ask. The characteristic about the rash, pruritus, pain and associated pruritus, pain or tenderness, progression of the rash, whether the rash appeared first after the fever, or fever came first and the rash came on the third day or fourth day. You have to ask like that. And history of ill contact or history of contact with some ill persons, travel history, insect bite history and medication history. Yes, then going to an examination, you have to know about whether it is a distribution of the rash. Then you have to know about the morphology and color of the rash. So first I am telling about macular rashes. Macular is a flat lesion. Flat lesions are macular type rash, while papular are raised or palpable lesions. Next, we're coming to morbilliform. What is the meaning of morbilliform rash? So, morbilliform rash is a characteristic name that is used for a rash, in a child with measles, that is called as morbilliform rash. So, in explanation, morbilliform rash means it is a coalescence of both macular and papular lesions into a diffuse sheet-like distribution. So, it is nothing but coalescence of maculopapular lesion into a diffuse sheet-like distribution, that is called as morbilliform rash. Next, third important question will be, this is your first and this is your second. Third will be whether it blanches on pressure or not. Okay, so why do you need blanching on pressure or not? Why? Because if the rash that blanches on pressure, if it blanches on applying pressure, it is mainly due to dilated capillaries. It is due to your dilated capillaries. If the rash does not blanch on pressure, it is mainly due to your extravasated leak, that is RBC leaked out of your blood vessel. It is mainly due to RBC that is leaked out of the blood vessel. For example, in dengue fever, there will be a leakage, capillary leakage will be present in like dengue fever or viral hemorrhagic fevers. So that lesions will not blanch on pressure, while your mosquito bite will blanch on pressure. That one you need to differentiate. Next, regarding the distribution of rash, you can see here what is this distribution and what is this distribution called as. So you have two types, that is, one is centripetal, another one is centrifugal distribution. Centripetal means more lesion will be present on the trunk and less on your extremities. That is like your chickenpox rash. This is your centripetal distribution. Centripetal distribution means more lesion on the trunk and less on your extremities. This is your centrifugal. So centrifugal means more on your extremities and face and less on the trunk. That is called as centrifugal distribution. This is your fourth point regarding the examination. So centripetal lesions or centripetal distribution are seen in chickenpox rash, while your centrifugal are seen in your what is called smallpox. Okay, so this is regarding the examination, whether you have to look for macular papular rash, morbilliform rash, whether it blanches on pressure or not. Next, whether it is a centripetal or a centrifugal. Next will be your other this everything comes under your examination only. Fifth one, suppose you are finding a target lesion. What is called as a target lesion? It is a well demarcated macules, that is a round macule which has a erythematous border outside, a slight whitish tinge or whitish ring inside, and with a dusky red or a bluish hue inside. That is called as your target lesions. So examples of your target lesions are, first one is your erythema multiforme. Erythema multiforme is a hypersensitivity reaction. It is a hypersensitivity reaction which will have a symmetric distribution involving mainly your upper extremities. Okay, and it will have a mucosal involvement, but that mucosal involvement will be limited to only one. Okay, so mucosal involvement will be limited to only one. HSV is a common infection associated with your erythema multiforme. Second example of your target lesion is your SJS, that is your Stevens-Johnson syndrome. The Stevens-Johnson syndrome is also a hypersensitivity reaction, but it is a severe life-threatening hypersensitivity reaction. Next, here there will be a mucosal involvement, but there will be more than or equal to 2 mucosal involvement. Okay, here with this one mainly it is a predilection for upper extremities, which is erythema multiforme. While coming to your SJS, it can involve any parts. Okay, and it will not be like symmetric or asymmetric distribution. It can be like distribution can be as of how the child is getting. So it is a life-threatening hypersensitivity reaction with more than or equal to 2 mucosal involvement. Okay, yes. Next, coming to your petechial and purpuric rashes. This is your petechial and this is your purpuric. So what is the difference you see in petechial and purpuric? This is petechial rash, this is purpuric rash. Petechial means it is a pinpoint lesion that do not blanch on pressure. So when it is not blanching on pressure, that means RBCs are leaked out from the blood vessels. So the pinpoint lesion that do not blanch on pressure. While coming to your purpura, these are larger lesions compared to your petechial. Purpura will be a larger one. So this is also a larger, dark, non-blanchable lesion. So since it is a non-blanchable lesion, so capillary leak is being found, blood vessel leak has been found in these lesions. What you have to do? The child needs an immediate and careful examination. So you have to order CBC with differential count and platelet count. Coagulation studies must be done. That is your PT and APTT. Then you have to look for CRP, blood culture sensitivity, because the child with Neisseria meningitis can also present with your purpuric rash. So you have to do a blood culture sensitivity, biopsy of the lesion, next CSF culture and cytology. So these are the investigations you have to follow when you find a child with purpuric and a petechial rash. Next will be your urticarial rash. Urticarial rashes are mainly due to your allergic reaction or drug reaction, but this can also occur due to your virus and bacterial causes. So the causes of your urticarial rashes are viral causes are your EBV and HIV. While coming to bacteria, it will be like Mycoplasma pneumoniae and group A streptococci. And other causes can be drug reaction. It can also occur in child with HSP. Okay. Next, coming to your vesicle and your bullous lesion. So vesicular lesions are a small, less than 0.5 centimeter fluid filled lesion. So vesicular lesions are smaller one, which are less than 0.5 centimeter fluid filled lesion, while bulla are larger than your vesicle, that is around 0.5 to 1 centimeter fluid filled lesions. So when you find a vesicle or a bulla in a child, what are the investigation you have to do? You have to consider regarding viral PCR for HSV, viral culture, then gram stain and culture of your lesion. Okay, these are the things you have to consider when you find a child with vesicular and bullous lesion. Next, coming to a distinctive rash. What is this type of rash? It is a erythema nodosum. This is a erythema nodosum rash. It occurs due to a hypersensitivity reaction, which manifests as a discrete tender nodular lesion on your extremities. So these are tender nodular lesion on your extremities. Okay, so etiology of this rash can be due to infection, inflammatory bowel disease, tuberculosis, or your connective tissue disorders. Okay, next. This is your erythema marginatum. Erythema marginatum, everybody knows it comes in your rheumatic fever. Erythema marginatum, on describing this, it is a serpentinous evanescent macular lesion with pale center. So it is a serpentinous evanescent rash with macular lesion and pale center. Okay, it this one can be one of the major criteria of your rheumatic fever. This can appear on warming up the skin. It occurs in child with rheumatic fever. Next one is your erysipelas. Erysipelas is nothing but caused due to a rare manifestation of your group A streptococcus infection. It is a rare manifestation of group A streptococcus infection. So this is infections of deeper layers of skin which have a well demarcated. This is a well demarcated bright red and a painful lesion. So it is an infection of deeper layer of skin. So the lesion is a well demarcated bright red and a painful lesion. Okay, next, this is your Escher. This photo is taken from my clinic in a child with suspected fever for child who had fever for 3 weeks, and they showed a lesion of this. This is your Escher. When you find an Escher, your mind should immediately go for your scrub typhus. Okay, this is a pathognomic, not a pathognomic, it occurs in 5 to 47% of the children with Escher. This Escher mainly occurs in your hidden areas, like this is in a genital region. Okay, it can occur mainly in your genital region, in your armpit, back of the neck, and only in the gluteal region. So it mainly occurs in your hidden areas. Okay. So Escher, the causes of a child presenting to you fever with Escher are: one is your scrub typhus, that is your rickettsial infection. Pseudomonas aeruginosa can also present with this type of infection. Next will be your aspergillus. Okay, yes. Next, this is your erythema migrans. So erythema migrans is pathognomic for your Lyme disease. It is pathognomic for your Lyme disease. It is a red macule or a papule at the site of the tick bite. This is a tick bite. So it will be a red macule or a papular lesion at the site of your tick bite. Next. So these are the unique or distinctive rashes that you need to remember. First one will be your erythema nodosum. Next is your erythema marginatum, erysipelas, Escher, and erythema migrans. So we have now described the causes according to the rashes. Now you have a simpler way. Another simpler way is when the child is presenting with the fever and rash, you have other associated symptoms also. With other associated symptoms also, you can classify the etiology, or you can make the etiology in a simpler form. So if you want to remember this is mainly for a practical purpose only. I'm writing it here. If you want to write this as a point in your exam, it is also better. Okay, so when the child is having a fever symptoms and also along with the rash with upper respiratory tract involvement, the causes can be measles, varicella, EBV infection, or your scarlet fever. Child with fever and hemorrhagic cause, mainly it is your dengue fever. Second one will be your chikungunya. Third will be your meningococcinia. And fourth, it can also be due to your HSV. Next, fever of acute onset. So again, will be your measles, varicella, leptospirosis. Fourth will be your Kawasaki disease. Fifth will be your toxic shock syndrome. While a fever with insidious onset are your SLE. Second one will be your vagus granulomatosis. Next, relapsing fever. Child with relapsing fever and rash, only because it is your Borrelia. Next, when the child have hepatosplenomegaly along with lymphadenopathy, the causes will be your infectious mononucleosis, leptospirosis, and your Borrelia. Next, if the child is having fever with myalgia and arthralgia of small joints, so small joints mean you have dengue, chikungunya, leptospirosis. Fourth will be your SLE. Fifth will be your polyarthritis nodosa. So actually common things are common. So the dengue, chikungunya, leptospirosis are common. Then you have to suspect if the fever is not settling with your antibiotics, or if it is relapsing, or if the child is having a high grade fever, then you will be suspecting SLE, bowel arthritis nodosa, and rheumatoid arthritis, that is systemic juvenile rheumatoid arthritis. Okay. Next, of course, if the child is having arthralgia of large joints, arthralgia of large joints, then your cause will be your HSP and acute rheumatic fever. Okay, so these are the child presenting to you with fever and other associated symptoms with rash. Okay, so this is how we have finished a child approach to a child with fever and rash. Thank you so much for your patience listening. Since it is a big topic, you have to read it, because you have to cut short. I have cut shorted this topic only. You have to segregate every points, and you have to remember. Okay, just don't by heart, just with your clinical knowledge and with your internship, while you're in PT period, no, in your internship, what all cases you have seen, just go keep that in the mind and go through this topic. Then you will remember every topic, every subheadings which you need to write in your exam. Thank you so much. I'll post this what is this PDF in our Telegram group also. Thank you.